Hello everybody and welcome to our session in using dashboards to improve the population health outcomes. The learning objectives for today is to evaluate the usefulness and effectiveness of population health dashboards, and to accomplish this we are going to be using a series of use cases that are going to illustrate how dashboards are useful and effective in contributing towards the population health. And when we think about this, we need to go back and understand how the growth of population it's also creating a growth in data and data sets that are available. And actually, measuring and reporting the outcomes of healthcare is a fundamental task for healthcare. And dashboards and data are used in order to improve the systems. And a data-driven approach that sometimes is called like the learning health systems, it's one of the ways to moving forward in improving population health. Then the technology is one of these factors that is facilitating to generate all this amount of data and aggregated data. And recent trends indicates that definitely the decision making that is driven by data, that is driven by these information systems, is going to be one of those methods that are going to really improve the outcomes. And we are today facing a lot of data integration, and the aim at the end is to see the whole person as an individual, and not only the clinical record or the problems, and see the individuals as in all the aspects of health. And we have touched topics in other classes like how we monitoring activities, physical activity, how we monitor healthy behaviors in diet or consumption or substances, things like that. And also the data integration and the need to have this is creating a lot of partnerships across all aspects of health. And here is where we have been discussing other times about interoperability and data exchange and things like that. And this is facilitated by a variety of clinical, structural, financial arrangements and community support that are aiming to remove barriers between the physical and the behavioral healthcare. And that concept that we have about what is health, that sometimes is focused on the disease but not necessarily focused on the health. And in this framework, then definitely having data integration and being able to share that and be able to create dashboards, we have the potential to guide program development, to mobilize providers to improve care or demonstrate the program value to different stakeholders. And in this order of ideas, we have the concept of the clinical dashboards that has been designed to display data to clinicians that can impact the quality of care in the individuals. But we can use the same learnings from the clinical dashboards and move that into the population health and be able to create impact in communities and populations. And in the clinical domain, we have demonstrated how the dashboards can be associated with reduced length of stay, the timeless of discharge, and we don't delay discharge of patients, improve patient outcomes, increase the grant funding, and the staff participation when the end user input is incorporated. Then these are things that we need to learn from the clinical dashboards, and maybe we need to start moving those things into the population dashboards and be able to recognize that the value that they are in clinical based interventions like clinical performance, monitoring of risk readmissions. This can be also moved into population-based interventions, and not only disease management, but in preserving the health of communities. Then, as I said, we are going to be approaching this by a series of case studies and different examples that are going to help us to illustrate how this can be done in the public health domain. And let's start with an interesting dashboard that is the public health dashboard created by UK. This is a dashboard that comes from UK, and this is a solution from the Office of Health Improvement and Disparities in United Kingdom, and they have a series of tools, and we are going to focus right now in the public health dashboard. We can have trends, we can have area profiles, and then we can have different geographies and different topics. And in these regards, then they have selected some main indicators of things that they want to see, and you can observe the profile, but you can also see the trend and how things has been changing over time. You can see not only that in England, but you can see that by counties. You can select a particular indicator, or you can have multiple indicators, and you can see how things are working, and you can contrast the different views and see if things are going towards an aim or not, and they're using the different colors and indicators. And actually they have this feature that you can download data and interact with them. These are interactive dashboards that people can just interact, modify, filter, download, and assess how these different topics, these different indicators are being observed and how they are behaving in the country and in the different areas of interest. And then depending on the type of data, then we are going to have different features that we can see, but and different combinations. We can see how we can compare different areas. We can have an overview of the values of the indicators across different counties, and if the trends are increasing, decreasing, maintaining. And this is really concerning, because this is child obesity, and we see that in general it is maintained or increasing, and overall is increasing, and this dashboard is kind of in red, and something is going on, and this is calling us for action. But at least it's telling us things are not going as we expect, or maybe in other aspects things are going better. Like in this case, the chlamydia detection is going down in some counties, and the adolescent pregnancy overall is lowering, even though there are some counties that it is maintained or a little bit of increase or above the expected indicators. Then this is a really interesting way of visualizing data, and that is going to support the decision making of policymakers, and be able to influence the programs, the policies, and the interaction. Let's look into another into another interesting dashboard, that is Data US or Data As. Then this is an open and easy to use platform that allows to extract knowledge from data, and it's a highly interactive. It allows millions of people to do their own visual analytics. They can create their own stories about United States, its people, places, industries, the skill sets, education institutions. They have different domains. This can be a powerful input to economic and workforce development. When we want to focus in some programs that are going to be increasing economy and workforce development, then this is a really good tool, and also is going to have some healthcare elements and some disease patterns and behaviors around the country. Then when we arrive to Data USA, then we can find that they have indexed 36,000 locations, more than 300 industries, 650 type of jobs, 7,000 universities, 1,800 titles, and they are looking into 254 products. This is a Deloitte product driven by a company that is called Data Wheel, and you can have some quick overviews of different states. Then let's jump into New York, for example, and let's compare New York with Texas. And then we are creating stories here just by the type of questions that we are creating. Then we can see that population of New York in 2020 was 20 millions, in Texas was 28, and New York is declining when Texas is growing. Poverty rate is more or less equivalent, and there has been a decrease in the poverty. The house median, it's a little bit higher in New York, and the employed population, we don't have the proportion, but it seems to be better employability in New York, just with rough things. And we can see here different data elements like diversity, COVID, economy, civics, education, housing and living, and health. Let's see what happened in COVID. How things are behaving. Then remember, we have New York, we have Texas, and we see that basically they have parallel behaviors in that indicator. But let's look into healthcare. Patients to clinician ratios, we have 1,194 patients to one physician. In Texas, there are less physicians for patients. Or we can look into dental care. How is the dental care situation? And then we have less dentists in Texas than in New York. And mental health providers. And we can see that this is disproportionately different in New York and in Texas. And other primary care providers, we have also a big disproportion there in the way that Texas and New York have a human resources for delivering healthcare. This is the access and quality of healthcare. Then this is actually this graph is about the homeless individuals, and the healthcare is down here. Adults who haven't seen a doctor in the last 12 months, due to cost. Then there is a problem in Texas, and we see that they don't have doctors. Mental health use. This one didn't update it, but as you see, the spending, coverage, health risks, there are a lot of interesting data that we can obtain from Data USA in order to create indicators. The Data USA dataset uses multiple data sources as the Agency for Health and Research and Quality, or the Bureau of Economic Analytics, Labor Statistics, Census Bureau, and they are doing this great integration from public available data and some private funded data collections like the Kaiser Family Foundation or the MIT Election Lab, but they integrate all this. And this is a really interesting tool that allows to create stories, to create visualizations, and to explore what is going on and create some kind of questions around different aspects of the picture of who United States is and how things are behaving. The tools that they use is called D3 Plus. We have not used D3 Plus in our classes, but it is an open access tool that is a programming suite that you can install into different environments, and this is driven by JavaScript, and then you can create a series of visualizations and that are integrated into your websites. And then this is another advanced tool for visualizations, and you can see different sites that incorporate the D3 Plus. Then the CDC antibiotic resistance, the Siren Observatorio, the Data Africa, Chile, USA, Mexico, that basically are the same type of sites with different data sources, Estonian statistics, Verizon, and they are really cool tools. Of course, we need to do a little bit of programming and be familiar with JavaScript, but if you are interested in doing that, this is a really attractive tool for creating visualizations. Now, the third one that I want to introduce to you is the Dartmouth Atlas. The Dartmouth Atlas project, it's a project from the university and document how medical resources are distributed and used in United States. This is using Medicaid data and some claims data and provide analysis about national, region, and local markets and how hospitals and physicians are providing services and what type of outcomes we are having in United States based on the Medicare. The data types that we have are longitudinal observations. We can have observations by year, or we can have our own selections and create our own data sets in order to create our visualizations. Then they have some already predefined data sets, and you can see the longitudinal or by year, and then you can have access to your data dictionaries, and you are going to have level of hospital, state, and communities. I'm sorry, I clicked the wrong one. Yeah. We can say expenditures, and the ones that allows to make your own data set. Then you have the table, and in this table you can just select what is going to be the indicator. You can select all years or a particular set of years that you are interested on, and you can select the different geographical locations that you want to use. And once you have selected your table, you notice that we are familiar with this tool, Tableau, and this is built in Tableau. You can just download. You can download like image or a cross tab, and you can save it in Excel or CSVs, and use these data sets to build your own visualizations. And the different things that we have, then we have medical reimbursements, end of life in patient care, care of chronically ill patients, primary care access to quality, post-discharge events, mortality, medical discharge rates, surgical discharge rates, the capabilities that we have, and some hospital research coding trends, and some tools that allow us to do geographical comparisons over the time, because some of the geographical relationships has changed, and they have created some special topics like COVID, the neonatal intensive care, aging populations, and they have some reports that I have created, and they also have the data that we can download. And this is a source to go for some specific data that is related with Medicare, but it's giving us some really interesting information about geolocation of those services, and how we are providing those services, and evaluate at least the public impact of some of the programs. And here we see some of the reports that have been created using the data that is available there in the data atlas, or the Dartmouth Atlas of Data. Then an interesting data source, and that allows to analyze healthcare delivery and not reimbursement, but billing from Medicare in the country. As you notice, some of the data sets, they have suppressed rates, and basically it's because if we have few patients, then it's easy to identify who are the patients, or if the rates are low, then they don't have statistical precision. Then it also allows us to understand a little bit of the data. Then there are some data that is clouded or just masked to avoid revealing some identities. There is another interesting tool that is called the County Health Ranking and Roadmaps program. This is a collaboration between the Robert Hood Johnson Foundation and the University of Wisconsin Population Health Institute. And the goals of the programs are basically to build awareness for the multiple factors that influence health. And this is now moving from just that informational dashboard or this interactive dashboard to be a more action-driven, action-directed, action-target dashboard. And they provide a reliable, sustainable source of local data and evidence to communities. This is based on communities in counties. It will help to identify opportunities to improve their own health. And the idea is to engage and activate local leaders from many sectors in order to create sustainable community change. And it's not just health, but they have a really, really important component in healthcare. Then let's take a look into the dashboard and see more or less what we have there. Then this is the landing page, and we can just look into what is the indicator of our community. And then we have New York, and let's compare New York with Houston. That was the comparison that we were doing. Okay, then I'm sorry, I didn't did the right thing. And let's go back to New York. New York. Okay, we have New York State. Let's do New York City. Then we have New York City. Then we have health outcomes, health factors, some demographics that we can have. And we can have a snapshot of the health outcomes about length of life, premature death, quality of life, and some factors that influence in the quality of life, some health behaviors, the discriminate like smoking, obesity, environment index, clinical care. Then this is access, social and economical factors, social determinants of health, physical environment, and then this is pollution, drinking water, driving, but this is just the exploration, no? And we can have overview by locations. We can download some data sets, but also we have the ranking model. And the ranking model is basically how they create an index for every single community, and they can rank communities, and then they look into programs, how they affect the health factors, they measure the health factors, and how are the health outcomes. They have different health outcomes that they are measuring, and then they can create this pipeline and be able to rank the counties and how a specific county compares to other ones. Then that's how this rank number 5 of 62 countries in New York are calculated. Then the ranking, then then we can see that Putman is the number 1, Tompkins the number 2, Saratoga is the number 3, Nassau is the 4th, and New York is the 5th. And we can see the whole ranking of the 62 counties, and unfortunately Bronx is the last one that has been rank in these regards. And here we can see also the mapping and the spatial distribution of the rankings, that we have some pockets and others that are neighborhood in some way, that are showing us geographically kind of some of the disparities that we can have in the outcomes that are related with social aspects of our communities. But the interesting thing, as I was saying, is not just that they have the ranking and they have the outcomes, but that based on their ranking, they have something that is the action center. And the action center the action center allows communities to assess the needs, focus on what is important, choose effective policies and programs, act in what is important, and be able to evaluate their actions. But how does it work actually? The way that it works is there are strategies that are suggested by different topics, then in health behaviors, in clinical care, in social factors, in physical environment. Then, for example, if you are interested in doing interventions in diet and exercise, then there are 76 strategies that has been reported, and here they are just listed, and then we can see different ratings of those strategies, but also you can see what communities are similar to you. They can have different learning guides or strategies for the purpose, and they also have a way of looking into the actions that allows us to look in then how, what, and with who. And once you go to different strategies, then it has by topic, by the type of decision maker, and the type of evidence. Then if there are things even that are ineffective, then there are 6 strategies, like for example juvenile curfews are evidence of being ineffective. Restrict the young to certain age of being in public places during certain hours, usually at night. About community safety, that's something that is not recommended. Retail alcohol sales privatization. Repeal government control over retail sales of alcoholic beverages, allowing commercial retailing for those beverages that is impacting the alcohol and drug use. And different elements or others that are really scientifically supported. Then you can start looking into different levels of interventions and actions, and different levels of evidence that apply for a particular community. And then you can explore, for example, smoking, then you can have the different sources, the key measures method, and how you can interact and the other resources that you can do to try to incorporate smoking cessation or different alternatives within your community. The next one is an interesting one. It's called the City Health Dashboard. The City Health Dashboard allows us to see social factors that influence different elements of the community in order to be healthy. This also is used by public health officials and other people that is interested in doing informed decisions and informed policy making. It looks basically into 35 social factors and is looking to health behavior, social and economical factors, physical environment, health outcomes, clinical care, similar to the ones that we saw in the community ranking. But this is not based on the counties or the small communities, or but is in the level of cities. And then we can access that in the you look like city health dashboards, and the URL is cityhealthdashboard.com, and in this case we are looking into New York City with a population of 8 million. The region is Middle Atlantic, and they have the website. Then we can have a city overview. Then this is the scale. Lighter colors are better outcomes. Then it tells us, oh, breast cancer, we are below the average of all the cities. Cardiovascular disease, we are worse than the average. Colorectal cancer deaths, we are better. COVID risk, we are above. Diabetes, we are above. Firearms, we are below the average of the country. And in this case I have selected firearms, and then you can see more detail related with firearms, and we can see social, economic, health behavior, the physical environment, and see all those dimensions. We can have the demographic overview, we have the census, but we can also have metric details. In this case I'm filtering by firearms, homicides. We can look into any of these different factors that we have told. And let's continue in firearms just in this case, and some data are up to date, some data are a little bit older, but that's fine. It has also the options to compare cities. Remember that we were comparing New York with Houston. Here. Yes, we are comparing New York with Houston. We can see how different we are, no? Homicides by firearms in Houston is higher than in New York, and then we can compare the other metrics, for example, obesity, and they cannot be compared in this case. The mental health, let's do visit here. Physical activity. Okay, then now they are comparable, and we have ways of looking into different metrics that are overlap in, and we can see how obesity and physical activity, they may have some kind of a correlation, and there's a collinearity in the observation, and then this is part of the things that we can do in the way that they are relation. But the cool and really interesting thing is take action. In this case, you can find policies and programs that are going to be similar to the ones that we have in the county rating. And then in this case, let's go back to the firearms and see, hey, what are the programs and policies, and say, oh, there are 17 programs that has been implemented around the country for firearms. Those 17, the background check on all gun sales, city gun violence, disarm hate, extremely risk law, gun dealer reform, gun law navigator. We can say, hey, there is no evidence and there is no promising promising practice on those programs, and we can filter this by policies or programs. And yes, unfortunately for this case, it seems that nothing seems to be working so far, and then there is still a big problem, no? And this is an opportunity for research, how we reduce the homicides that are related to firearms. But let's see, in obesity, we change the indicator, then there are 28 results, and then now we have that 23 out of the 28 are evidence-backed, and then there is more evidence in how to attack community obesity from the community point of view. That is for the firearms. And here, if we want to target community organizations, then it's saying, okay, yes, evidence says that create and improving places for physical activity is important, designing sugar drinking taxes, health food procurement, individual adapted health behavior, obesity programs, obesity prevention and control, safe routes to school, and self-measured blood pressure interventions. Then those are the most important elements that we have in this type of dashboard that can associate this data that we have from other sources and be able to filter and give us tailored recommendation. And here we have some interesting stories, success stories, where some of those programs have been implemented and has been successful. Then this is a really interesting use of dashboards then that are modifying outcomes. Another examples are a little bit more local, and then end of the epidemic dashboard tracking the HIV program and policies in New York City. There was a dashboard that was created by the school. It was adapted from existing human-centered job visualization platform that is called Cenevis, and we are going to show that a little bit. This is an internet-based interactive app incorporating principles of human-centered design in order to visualize population data. The initiative of ending the AIDS epidemic tried to identify persons with HIV who remain undiagnosed and link to those link them to healthcare, and link and retain persons that are diagnosed with HIV into the healthcare to maximize the virus suppression, and then they can be healthy and prevent for transmissions. And the ultimate goal is to facilitate the access to the pre-exposure prophylaxis plus those persons that are engaged in high-risk behaviors and keep them HIV negatively. then this is an initiative, as I say, from the school. The tool then measure, tracks, and disseminate information, and we can see here how they depict goals and the measurement and how the city is doing, and they have several metrics and several targets and how things are projected. You see the opportunity data is not that fast, but we can have some idea of what is going on there. And the most important thing that we need to reflect here is definitely how we are going to be updating data, how we are going to be collecting that data, and how we are going to make that visible and usable. But this is a product from the school, and it's out there, and it's an example of things that we can do, and this may serve as inspiration for your capstones or your EPID 700 works. Things like this could be interesting things that you can try to partner with some faculty members or other classmates in other programs in the school, and be able to create interesting tools. The data sources, then they have several data sources. They are using New York Department of Health, some community health survey, another electronic reporting, the Dataverse, and you see this is also an integrative tool from data sources, and as we saw, then we can create different visualizations and indicators of what is going on based on those data sources. The other dashboard that was created in the school is well-being in New York City. This is using similar methodologies, and this is to track mental health in New York and use the well-being scale. And basically this is a self-reported scale, and this was a pilot that was created to track what the individuals in New York were feeling and be able to try to detect where mental health issues were. And you can compare yourself with the community, and it offers resources, and this is a end user base, and this is kind of a little bit of the evaluation that they conducted. Another derived project is the Smart Dashboard for mapping the social determinants sustainable development goals in urban slums in India, for example, and then they follow the different elements and be able to do interventions. All this was based in additional work that Ashish Joshi, our former Associate Dean of Academic Affairs and the creator of our program in Sanavi's Health View, that was part of his dissertation. That was a project for visualizing data services in Brazil and how they were being delivered. Then all these are really useful tools, but there are always going to be concerns about confidentiality and privacy. And we saw how, for example, just masking the data or not providing even aggregated data in some domains is going to be able to protect in some way individuals, because with enough data we are able to re-identify people. Then these concerns, sometimes personal data may be exposed, they don't have access, then we need to be really mindful how we are going to be creating that. And it's not just that we don't have the 17 identifiers. Maybe a diagnosis and a zip code is enough, or a particular description of demographics with a zip code will be able to identify somebody. Then we need to consider various aspects of data collection, storage, presentations, and this integration, how we are going to be updating, how this is going to be really live in order to be able to provide reliable services. Then as a conclusion, we can say that dashboards can provide a way to integrate different population health data streams and offer experts useful tools in order to assess the epidemiological situation or what we are doing and go further. Try to plan actions and see evidence of the actions and try to link them. Then this is the reference for some of the things that we did and some resources that are interesting, and I invite you to look. Thank you for your attention and have a wonderful week.